Welcome to our video on microvascular complications in diabetes, focused primarily on neuropathy and diabetic foot issues. So let's get started. Diabetes is the most common cause of peripheral neuropathy. As we've discussed in other diabetes lectures, this is both the result of a direct toxic effect of the hyperglycemia, because it actually damages the neurons. There's also microangiopathy of the blood vessels that actually supply the nerves. Now, it affects the longest axons first, and that results in this glove and stocking neuropathy. So naturally, the patients are first going to get these symptoms on their feet. Now, the common forms of this diabetic neuropathy we're going to discuss are distal symmetric sensorimotor polyneuropathy, some mononeuropathies, and autonomic neuropathies. Distal symmetric sensorimotor polyneuropathy is the most common neuropathy seen in diabetes. Now, it can be classified into large fiber neuropathy and small fiber neuropathy. Now, the large fiber neuropathy usually has negative symptoms, such as a loss of something. For example, loss of vibratory, pressure, proprioceptive, and light touch sensations. And there would also be a diminished ankle reflex. So typically patients do not notice those symptoms, so they're mostly asymptomatic. On the other hand, small fiber neuropathy is associated with positive symptoms, such as the presence of a burning pain, allodynia, which is the experience of pain from generally non-painful stimuli. The patient can also have paresthesias, and that's the feeling of that pins and needles sensation in the absence of pins and needle stimuli. And with this small fiber neuropathy, patients often have reduced pinprick sensation. So if you were to think about which type of neuropathy is going to present in your diabetic patient, that would be small fiber neuropathy. But you can discover large fiber neuropathy on your physical exam. Just don't expect your patient to complain about those. Now, the loss of sensations and peripheral artery disease of the lower limbs can actually give rise to what we call the diabetic foot. So when we say the diabetic foot, we're referring to foot ulcers, infections, and joint deformities. And it actually makes sense why this would happen. So because of that inability to sense pain, even minor injuries in these patients can go unnoticed and they can progress to full-blown ulcers. And many patients have concurrent peripheral artery disease, which exacerbated the condition by inhibiting timed healing of those wounds. So you've got this patient who doesn't heal wounds in the best of circumstances, even when they know they are there, but then they don't know they're there and they don't heal. So you get these long-standing ulcers. So these diabetic foot patients are prone to infections. And unfortunately, these infections can spread to the bones and joints, and that can destroy the bones and joints, and it can even cause life-threatening sepsis. Now, if a patient has an ulcer and you can't control it through medical efforts, then they most likely will require some surgical treatment, and oftentimes that results in amputation. Now, a 10-gram monofilament test is a test to detect the pressure sensation in the feet. And actually, this is the best predictor of the risk of developing a diabetic foot ulcer. So this should be done routinely on diabetic patients. You want to see if they can feel that filament. So with all this in mind, it makes sense that you're going to regularly do a comprehensive foot examination on all your diabetic patients. And it's recommended that this is done annually. In addition, patients are strongly encouraged to regularly inspect their feet for any injuries or wounds. So have them do this on their own. And all of the high-risk patients need to be referred to a podiatrist where they can get specialized diabetic foot care. Now here's an image showing a diabetic Charcot-arthropathy, so the diabetic joint. And notice that marked swelling. And there's also a visual deformity of the foot. Next, let's talk about mononeuropathies. These are generally due to axonal ischemia, and they're generally more severe and have a rapid onset. The oculomotor nerve, cranial nerve 3, is the most commonly involved nerve, and it presents with the typical signs. And these typical signs are diplopia, ptosis, and the down and out eye. In that case, the pupils are spared, so you wouldn't see any mydriasis. Now, the selective sparing of pupils in diabetic ocular motor palsy can be explained by the specific arrangement of the nerve fibers within the oculomotor nerve. In an oculomotor nerve fiber, the parasympathetic fibers responsible for meiosis of the pupil are actually in the periphery, whereas the motor nerves that supply the extraocular muscles and the levator palpebrae superioris, the one that controls the eyelid opening, those are in the center. And since blood vessels lie close to the periphery of the nerve, the parasympathetic fibers are less vulnerable to ischemia, especially when compared to those motor fibers, which are further away from the blood vessels because they're more central. So what happens here is there's this selective sparing of parasympathetic fibers in ischemic mononeuropathies, such as diabetic oculomotor nerve palsy. Now, there's also some compression neuropathies which can occur, such as median nerve compression causing carpal tunnel syndrome. And there can be compression of the common peroneal nerve, and that can cause foot drop. Now, the involvement of autonomic fibers is associated with a poorer prognosis, and the treatment here is just heavily supportive, and it actually depends on the exact symptoms that the patient presents with. The most important manifestations of autonomic neuropathy are erectile dysfunction, a neurogenic bladder, orthostatic hypotension, and some gastrointestinal involvement. So let's talk about these a little bit more. So a neurogenic bladder typically presents with urinary retention. This is due to the reduced detrusor muscle activity, but can actually eventually progress to overflow incontinence. So the bladder just gets so full, it's never squeezing stuff out, and at some point, urine just leaks out. We call that overflow incontinence. And when it comes to orthostatic hypotension, this occurs because there's neuropathy of sympathetic fibers. And that makes sense. When you think of that fight or flight situation, you're running from a bear, it's the classic scenario. You need to have your vital signs go up. You need your heart rate to go up and your blood pressure to go up. But if you don't have that sympathetic fight or flight response where those nerves are damaged in some way, then you're not going to be able to do that. So when a patient with this autonomic neuropathy stands up from a seated position or a laying position, then they can actually have hypotension. They can get lightheaded, and that's called orthostatic hypotension. Lastly, involvement of the GI system can present with multiple symptoms. And so let's talk about those here. We've got gastroparesis. So that stomach just isn't contracting well enough. It's paralyzed. Gastroparesis. There can also be diarrhea and constipation. Let's dive into this gastroparesis idea a little bit more. So this is an autonomic neuropathy, and it affects the stomach. And so as I alluded to on the previous slide, this causes slow gastric motility. So the delayed gastric emptying and this delayed digestion leads to early satiety. They just get full faster. Things just aren't moving through. And they can also have abdominal bloating and pain. And naturally, the patient can also have nausea and vomiting. Now, the slow absorption of glucose, because the stomach's just not moving contents through fast enough, means that the patient can actually have these hypoglycemic episodes, even though there's no change in their insulin dosing or a change in their meals or physical activity. So thinking about their physical activity and their routine of insulin dosing and their meals, if that has not changed, but they're still having this hypoglycemia, then that gives you an important clue that maybe some autonomic neuropathy has developed and their stomach is actually experiencing some gastroparesis. Now, it's also important to recognize that these patients may not have the typical hypoglycemic warning symptoms, and that's because of the advanced neuropathy. So early on in their disease course, they may be able to have those symptoms that you see and it freaks you out and it causes you to address it. But because of this advanced portion of the disease with this advanced neuropathy, they can actually lose consciousness super quick, or at least it appears that way because they've been hypoglycemic and then loss of consciousness. So be careful with that. Now, the treatment is metoclopramide. This actually has antiemetic action and can be beneficial for patients who are vomiting as well. Again, these diabetic gastroparesis patients can have vomiting. So you're treating one of the side effects, the vomiting of gastroparesis, but also helping to just get motility moving. So metoclopramide is a very good option for these patients with diabetic gastroparesis. Now, another option is erythromycin. And this is an antibiotic, but it's actually really helpful in this case, not because of its antibiotic properties, but because it actually increases GI motility because it acts on motilin receptors. Now let's do a question to apply what you've learned so far. So what's the best test to predict the risk of a patient developing diabetic foot ulcers? Feel free to pause the video while you consider the answer. So the answer to this is a 10-gram monofilament test. Remember, this is just a simple test, but it's a very objective way of screening diabetic patients for that loss of pressure sensation. And that concludes this section.